at Empro Insurance. It's my great pleasure to introduce Dr. Gurpreet Dhaliwal this evening. Gurpreet Dhaliwal is a clinician educator and a professor of medicine at the University of California, San Francisco. He sees patients and teaches medical students and residents in the emergency department, inpatient wards, and outpatient clinic at the San Francisco VA Medical Center, where he directs the internal medicine clerkship. He studies, writes, and speaks about how doctors think, how they make diagnoses, how they develop diagnostic expertise, and what motivates them to improve their practice and the systems in which they work. Dr. Dhaliwal is a member of the UCSF Academy of Medical Educators and the UCSF Department of Medicine Council of Master Clinicians. He has published 125 articles and has been a visiting professor at multiple universities across the US, China, and Japan. He's received multiple teaching awards, including the 2019 UCSF Osler Distinguished Teaching Award and the 2015 National Alpha Omega Alpha Robert J. Glazer Distinguished Teaching Award. Tonight, Dr. Dhaliwal will be speaking about a very relevant and important topic, social determinants of health, what you can do. Dr. Dhaliwal, a warm virtual welcome to you.
Virtual gratitude, Kristen. Thank you so much for that introduction. And thank you everyone for joining me wherever you are and whatever time zone it is. I know it's towards the end of the day, so I'm grateful for you spending time with me. What I'm going to talk about today is something that I'm on a growth trajectory on. All of us as clinicians grow and evolve, and we move into different areas in order to improve our practice. And I can measure things I've done over time to try to get better, whether it's at reasoning or high value care or bioethics. And this really is the area that I'm trying to make my greatest improvements on, both as a practitioner and a teacher. And so what I want to do today is share my journey on the social determinants of health, how I'm incorporating it in my practice, and emphasize that it's something that we all can work on. I want to juxtapose it also against another force in medicine, which is the move to personalized medicine. So we always hear about the excitement that we have about personalizing medicine and making it precise. And the premise behind it is that if we can understand people's genetic codes, we'll learn that every person is a unique version of the human genome. And I am wildly enthusiastic about that when we drill down to the genetic level. But I also want us to sort of think about how every person is also a unique version of the human experience. And that probably underpins more than anything else what the social determinants of health really mean. To start out with, I'm going to ask us to launch on a poll. So if you have the capabilities to participate in the Zoom poll, they'll be here. I'll read it for you, which is, which of the following is most strongly associated with life expectancy? Your place of residence, your LDL level, your genetics, or the access to healthcare that you have. So try to pick one of these. We'll let go maybe another 10 seconds.
Sure.
Okay, I think we're pretty good, Stan. We'll close it out and we can show the results. So this is like the presidential election with 71% of the polling stations in. The results are that almost half of us suspected that healthcare access is what accounts for life expectancy. And this is in the United States, I should say. And this is a bit of a tough question because although all the answers are right, some are more right than the others. So I think the results have been shared here once again. But the correct answer in this one, which is something that I have learned over time, and it took me, oops, let me advance here, is your place of residence. So one of the most striking things in our country, but really across the world, is that there are many things that determine how long we live and how good a life we live. But the major determinant in many epidemiologic studies are where we are born and where we live. And just to give you an illustration of this across 3 different regions in the US, even though the database that I draw from, which is from Virginia Commonwealth University, shows this. Here's an example of someone being born in Virginia, and even along a single, in New Orleans, and even along a single highway, stretch of highway, you can see that you can have a difference of between 25 years of life simply as a function of where you're born in that city. It's not unique to New Orleans. You also will see this in New Jersey, where you can see that even in a span of just going down the highway, you'll see a difference of almost 15 years of lifespan, simply as a function of where you were born. And all those things that we voted on matter, but where you're born is the biggest predictor of all. And then closer to home where I am, I'm a general internist and a clinician educator in San Francisco. I work full-time, I should mention, as a way of introduction. I've been in practice for about 20 years. I'm a general internist. I work in the emergency room as a hospitalist and a clinic doctor, and I work 5 to 7 days a week in all of those jobs. South of me in the San Joaquin Valley of California, the same situation. How far I live along the I-99 determines how long I'm going to live, at least on average. And sometimes it just matters which side of the road I live on. And what all of these give us insight into is that as much as we're paying attention to precision medicine and our genetics, we're sometimes learning now that oftentimes it's not your genetic code, but it's your zip code that determines how long and how good a life you're going to live. And to illustrate this, I'm going to walk us through a video and snippets throughout this talk that tell us about how the social aspects of our patient's experience determines the health that we interface with them on. And I'll start you with the first clip on this video here.
Even before we're born, there are factors at play which influence our health and well-being. The conditions in which we're born, grow, and live can affect us and our health in different ways. We also react to them in different ways. Poverty, stress, lack of adequate housing, education, unemployment and poor access to transport and nutritious food are some of the things that can affect our health and life expectancy. The World Health Organization recognizes that health and well-being are strongly influenced by social, economic, and environmental factors known as the social determinants of health. The environments in which we are born, grow, live, work, and age can have stronger influences on our health than our genetic family history or behavioral risk factors. A person's social and economic circumstances affect their health throughout their life. The relationship between income and health is on a gradient. This social gradient means that even a little bit of wealth can increase your likelihood of being healthier. A stable source of healthy food, appropriate, affordable and secure housing, education and employment, relief from financial distress, access to transport and services, loving and stable relationships, and being able to make choices about our lives means we are less likely to experience chronic conditions such as diabetes, cardiovascular disease, depression, anxiety, and other mental illness.
So we're going to come back to this video as it plays throughout this talk, but I want to emphasize that there is a protective effect when many of the social elements of our life, whether it's family or economics or security or food, are in play. And we'll visit that when we say, how could those possibly mediate health in society? As a starting point for the theme of this talk, which is what can a doctor do? What can a practicing clinician like me or you do when sometimes you feel like, listen, I can't save society, I'm trying to save lives or save people in my clinic, is that there's actually quite a bit that I've learned I can do to make my contributions to my patients and acknowledge that factor in their health. One of the key things starts with the communication that I have with my patients in clinic. And I'm going to share two books that really have been my Bibles. They are my resources in terms of where I've gone. One is called Communication RX, and the other is called Compassionomics. And the two together, as I've read, and each of them I've read twice in order to try to improve my communication with not only patients who suffer inequities, but all patients, have really transformed the way I think, where I stop going into the clinic room trying to say, like, what's the matter with you? And I now start to enter the room saying, what matters to you? Like, what is going on in your life, and how does this health problem fit into a life that you care about? And there's so many gems and pearls that I could draw from those books, and I just want to plug them as strongly as I possibly can. I have no financial interest in either, just an intellectual interest in both. But the key takeaway when we're dealing with people who will come from all walks of life is to start with relationship-centered care, which means quite simply that the person is of interest to me, not just the medical problem that they have. And some core tenets of that approach that really undergird our care of patients is being social. That means that when I meet them, I don't lead with their medical problem. I don't lead with that thing I was taught in medical school, like, so what brings you in? I try to learn just a little about the person. How was their trip in today? Where did they come from? What's that jersey that they're wearing? Just 30 seconds or so of personal connection before we get down to business. The second is that I try to learn to take a social history. Now, I think many people here are probably listening to that and they're saying, well, social history, I learned how to do that in med school. And I did too, but what I learned in med school was that your social history is how much you smoke and drink and if you do drugs. And that has proven to be a rather impoverished way to try to understand someone's true social worth. When we talk about social determinants of health, we really mean like, what is the world that you live in? Who do you spend it with? And how do you spend your time? So in our medical school and residency now, we teach our trainees, social history means those questions. What's your job? Did you serve in the military? Who's at home with you? What do you enjoy? And the things that we used to learn, the smoking, drinking, drugs, goes in a separate section that's called health-related behaviors. And I oftentimes find myself falling up short if I leave that as a separate section and know I have to go back and fill it out to really know my patient. And then the most important thing is to lead with compassion, that I really care about you. And whether it's that initial opening or the way I close, I hope it's clear that I care about what matters to you, not just what's the matter with you. I was reminded of this when I was taking care of a patient who came in a few months ago, and he had two sort of disparate problems. He had traveled a long ways at my referral hospital, the VA where I work at, and he had some arm pain. It was in his upper shoulder, and then he also had a rash on his legs. And patients oftentimes come in for sort of a 2-for-1. And I said, well, you know, your shoulder sounds like you have rotator cuff tendonitis, and your rash, like many rashes on your leg, I'm not sure exactly what they are. I have a hunch that steroids are going to help out here. It looks like there's some sort of irritation. But I had started with sort of also learning about like, you know, what's going on. And I said, you know, what activities could you be doing that might be affecting your arm? You told me to start chopping wood. I said, that's interesting. I said, how come you're chopping wood? He said, well, I've been chopping wood because that's how I'm keeping my place warm. And I said, oh, you mean to heat your house? He's like, yeah, I have a small house out in the wilderness and it's very hard for me to pay for my electricity bill. So I try to keep it as low as possible by heating it with wood. And he's like, but the temperature was getting cold. It was winter when he was coming here. And he's like, so I really basically have the heating off as often as possible. But I did get these new socks from Costco with acrylic lining, and I've been putting them on, and they feel really warm, but I gotta say, doc, they itch. And in one fell swoop, I figured out that everything that was happening to this person, whether it was his rotator cuff tendonitis from swinging an axe to break wood in order to heat his house, to the Costco socks. And I love Costco. I'm not knocking on Costco. I get a ton of stuff from there. But those socks were undoubtedly accounting for his rash. And all of that came from one core problem, which is he wasn't able to afford his heating bill. Is a very close example of how just being a little bit social with someone and caring about their world rather than just the problem that they have allowed me to form a connection. And that is my point about the small micro teaching point I've learned is being social isn't just about being nice. It's actually really good medicine, because when we talk to people about their social world, yes, it helps us solve diagnostic dilemmas, but it also helps us understand some of the social things that are going on in their life. And so I've made it a point now to ask about it. And when I ask and have enough of a conversation, oftentimes something in this realm comes up, and it's something that I wouldn't have known to ask about before. But this schematic here are what those social determinants of health can be. So I'll give you 10 seconds just to reflect on it, and then we'll pick up on that video where we left off. So here's picking up on that story where we left off of that little icon, the green eye button, who's our patient, who before explained that when circumstances are good and you have healthy food and great education and great employment and transportation, that really is protective against a lot of health problems. We'll rewind the last 5 seconds of the video and then go on to an alternate scenario.
And being able to make choices about our lives means we are less likely to experience chronic conditions such as diabetes, cardiovascular disease, depression, anxiety, and other mental illness. How we are treated by and interact with others also has a huge impact. Stressful circumstances over a long time that make people feel anxious or unable to cope, discrimination, racism, social isolation, or just being treated as less than equal can lead to poor health. And the interplay between these factors and a person's socio-economic circumstances can compound the situation. Experiencing a lot of stress and feeling unable to change things can also lead to poor health.
And I want to pick up on that point. I think there's 2 points that were made there. One is when we talk about social determinants of health, it may be the circumstances, being in a place where food or safe transport or unemployment or employment or education isn't available, but also that other part about how you're treated by others in society. And they made the point that the two compound each other. And as a clinician, you have to be sensitive to it, or at least understand that as part of our differential. But the other thing they mentioned at the very end of that video is that makes change very hard, because it seems like it's hard to change someone's circumstances, or oftentimes a behavior that's emerged from those circumstances. And there's oftentimes behaviors that we're quick to blame people on when we don't understand there might be a structural reason for doing it. I was reminded of this and the importance of seeing someone on a human level. If you're trying to help someone who comes from a world that's different from you, or has a belief system that's different from you, it's rare that you'll persuade them with facts. But if you can see them as a human with dignity, you oftentimes can understand what they're thinking and going through. And I was reminded of this when I read a recent tutorial. This was by Dr. Kimberly Manning. Dr. Kimberly Manning is a professor of medicine at Emory University. She is a brilliant teacher, clinician, and perhaps above all else, she's an amazing storyteller and writer. So she has written blogs and articles, but in the last couple of years, she's really taken to Twitter. And that is where she tells the stories of her life and her patients at Grady Hospital, which is the safety net hospital in Atlanta. She posted a tutorial where she was talking about trying to get a patient to take a flu shot. So I'll narrate some of this too, and I'll try to set the stage. There's an older woman who's ready to leave the hospital, and the resident has been trying to get the patient, pardon me, has been trying to get the patient to take a flu shot, and the patient isn't having it. So Dr. Manning tries to jump in. So Dr. Manning, underneath, she says, okay, so the only thing left for us to do is your flu shot. Patient, oh, you think you're funny, and you think you're slick. So they have a laugh. Then Dr. Manning says, what? And the patient says, you know, he told you I ain't taking no flu shot. And he points directly at the resident. And Dr. Manning confesses. I should say this goes on for many, many tweets. And Dr. Manning, she's a brilliant writer. She switches in and out of Black vernacular English and just modulates it so brilliantly in capturing her characters and patients. So they go back and forth. And Dr. Manning really tries with facts. That's what we're educated on as doctors. So she talks about how the flu vaccine will reduce COPD admission, CHF admission, pneumonia potentially, how it's trending in Georgia, how the heat map shows that there's tons of flu there. Like, she's coming in hot with all of these facts. And the patient isn't having any of it. She said, listen, I've been on this earth since 1941, and I have never needed a flu shot. There's no need for me to start now. And Dr. Manning sort of recognizes that she's met her match. And so she says, all right, that's fine. She's like, let me just start to talk to her, sort of get to know her. Remember, like, go social and get a social history. She's like, what do you do? Well, she learns that this elderly grandmother is the matriarch of her family, and she has a number of grandchildren aged anywhere from age 20 to 6 months old. So she gets to talking to her about her routine, and she learns that she takes care of the young kids while the parents go off to work, particularly the 6-month-old. And so she says, hey, you take her to the doctor? She says, oh yeah, I take her to the doctor for sure. She said, you're the transport? She's like, yep, I know that pediatrician. And she said, does your granddaughter, does she get shots? She said, oh yeah, she gets all her shots. And then Dr. Manning's like, how come? Like, why'd you get her all those shots? And she says, well, I mean, she is our precious baby. She is the one that our family loves more than anything else. I don't know what would happen. What I would do if something happened to that baby. Dr. Manning senses an opening here. She says, I bet you those grandbabies don't want nothing happening to Big Mama neither. The patient and her both sit in silence. And the patient says, you think you're slick. And Dr. Manning says, I'm the slickest. Of course, what happened there was Dr. Manning wasn't trying to fool her by getting a social history, but by learning someone's social history, she saw an in to allow the patient perhaps to realize how a change in behavior based on her world, not our biomedical world, was going to be in her best interest because of something she valued so much. And what Dr. Manning really engaged in there, even though she doesn't use this word, but I think many other commentators is that she did what's called motivational interviewing. So often when we're dealing with patients who come from a different walk of life and have a different set of beliefs or a different world than we believe, we'll say, well, what would it take to help this person move into a healthier behavior? And for years, we've tried to cajole people with facts. And what we know is that facts rarely change behavior. You can teach people about the facts of condoms for safe sex, or flu shots for respiratory illness, or now for masks in COVID-19, but facts rarely motivate people. And it gets to this essential truth that people don't resist being changed. They resist being changed by other people. And when we want to help all communities, one of the greatest tools we can use is what's called motivational interviewing, where you no longer try to sell someone on something, you just have a conversation that lets them envision a better future for themselves. So what does that look like if we try to model it when we are trying to help people navigate these social determinants? Here you see that this grid that I put here called motivational interviewing, and it's really a way to help walk people through something where they would say, if you change something, losing weight, stop smoking, taking my meds more often, going for a walk, whatever it is, just help me fill out this grid and say, what things would you like if you kept things the same? And if you made a change, what would you like and what would you regret? Because you might talk to someone about smoking, for instance, and say, how willing are you to stop smoking? And smoking, by the way, like many things that we think are willpower, are oftentimes a structure of some other exposure in their life. Like it might be that they're in an environment where people smoke. It might be, in my case, I work at the VA hospital where they served in the military. But that structural factor is that the military gave the GIs tons and tons of smokes and encouraged a habit, which for many of them became a lifetime one. Which one of those things are at play that might have accounted for it, we can't know, but we're here today and we want to help them do this. And so you might say, well, tell me about your smoking. What do you like about smoking? Because I asked you, do you want to quit on a scale of 0 to 10? And you didn't say 0, you said 2. Why is it a 2? You say, well, I mean, the thing I like about it, doc, is it's social at work. And it's a habit I'm used to. But if you do ask me what I don't like about it, I really don't like that as an example, that my kids see me smoking. And that's something that concerns me. So that's why it's a 2 out of 10 on my motivation to change, not a 0. But you're right, I do like it. And I say, all right. And then say, can you help me envision what it might be like if you change? I'm not a smoker, so I don't know. This is that point about crossing divides. Like, I don't live in your world, but if you did change, what would you like about it? And what maybe you wouldn't like about it? You can share that with me. And you say, well, doc, if you ask, actually what I'd really like is that it would make me a lot more productive in work. I mean, I do like those smoking breaks, but to be fair, like I lose a lot of the time getting stuff done because we're out there just sort of chit-chatting. And boy, I could really use less of a cough. That smoker's cough, I mean, it was one thing all these years, but now with COVID, if you have a cough, everyone runs the other direction. So I think I could stand to get rid of that cough. But I got to be honest with you, I wouldn't like the cravings, and I hear that you can gain some weight. So that's something. And you might ask, okay, thank you. I really appreciate you sharing that honesty. I'm not here to give you a sales pitch, but what would it take to maybe move you over to there? Now that we've talked about it, is your motivation to stop smoking 2 out of 10? And they might say, well, now that I've talked to you about it, like maybe it's a 4 out of 10, and I'd consider that gum, but maybe next time when we meet. And you see what's happening there when we're trying to help people change, when the world has dealt them some cards, that we do need to help them change. But using motivational interviewing says, like, I respect your world and I want you to change on your own accord, not because I tell you. And to understand that people change really because they know their world better than us and understand the pluses and minuses. So I want to give you just a moment, if you can, to think about something in your life. We can't do this in the virtual environment the way we could do in person, but I just want you to think about something in your life and say, the way it is now, if I kept things the same, the things I like and I don't like are this. But if I made a change, the things I like and also won't like will be this. So you can decide if this is a professional challenge you want to make for yourself, a personal challenge like dealing with your children or your exercise or your diet. But fill out this 2x2 grid and see, I'll give you just 60 seconds to do this, and I'll come back. All right. The key principle is that this, just like the communication that I mentioned at the beginning, is a core tenet of great clinical communication under any circumstances. But when we're trying to help people change a behavior or a habit or circumstances that's no fault of their own or something that's evolved from the world around them, it doesn't mean that we're powerless to do it. Like I said, doctors can't fix society in the blink of an eye, but we can help people adopt a habit, a healthier habit, over the course of single or multiple interactions. And that is contributing to and sometimes combating a social determinant of health. So think about this approach when the time comes to change. People don't resist change. They just resist being changed by other people. But if we can use techniques like motivational interviewing, we have the potential to help them along and change towards a healthier behavior. When we reflect on what our job is, we're talking about social determinants of health, but there's two elements to consider. One is that we are really in the business of improving lifespan and health span. And the two are related, but they're not the same thing. Lifespan is how many days, years, and months that I walk on this earth, how long I'm on this earth. But equally important is the health span. The health span is how much of that time that I spend on this earth is healthy and happy the way I measure it. Whether it's spending time with family, being able to work, just being in general good health, but it matters to me, that my life matters to me. But the only way a clinician could ever know that is by getting to know the patient on a personal level. So when we talk about what our goal is or what our job is as clinicians, we are trying very hard to maximize people's lifespan, but also maximize their health span. But when we try to do that, one of the things that we recognize is our role in it may be a little smaller than we think. There's many studies that sort of ask, like, when we talk about people's health span or lifespan, what are the factors that go into it? And as a doctor, I would think like, well, it has to be just genes that you're given and then the doctors that you see. That would have been my answer 5 or certainly 10 years ago. But as study after study has come out, some of these things predating from when I and many of us were in med school, we just never paid attention to it or knew it. Was that healthcare is only a small piece of the puzzle. And if we really are interested, really interested in improving the health of the people we have to take care of as a society, then we have to improve that society itself, not the healthcare or medical system. And that has been one of the biggest lessons of the social determinants of health that I have integrated. Now, remember what we're trying to do in medicine, aside from improving people's health span and lifespans, we're trying to do that in the constraints of our healthcare system. We're trying to do this triple aim, which is to optimize people's health, to do it in a way that's affordable for our system and our country and each person, and also have an experience which is respectful and as pleasant as possible for a patient, but also as fulfilling as possible for the healthcare providers who are there. And that triple aim, or sometimes called the quadruple aim when we talk about the healthcare providers, is not easy to do. It is a balancing act with a series of trade-offs that are innumerable. But one of the things that has struck me is that I've always brought my biomedical lens to achieving the triple aim. Just the thrust of medical science is the thing that might help us along. And videos like the one I'm going to show you here showed me how I've had to expand what I think about if I'm really trying to achieve this for the system at large, for the place I work at, or honestly, just the patient who's sitting in front of me. So take a listen to the story of this patient who's having some problems with her blood sugar and her diabetes. It's narrated by a physician.
Let's imagine a patient. Let's call her Mrs. M. She's 46 years old. She's got 2 kids. She's got a mother. Her mother is a little frail. We're trying to take care of her. She has type 2 diabetes. It's not really well controlled. She's got some mild heart failure as well due to some issues that happened when she was a kid. She's holding down a job. She's got a high deductible health plan with her employer. She's trying to make ends meet. She's dignified and takes her responsibilities very seriously. She makes sure that her kids get to school, are fed, are doing well, and taking care of her mother, who relies more and more every day on her. So let's take Mrs. M. What does the triple A mean for her? Well, we know that in Mrs. M's story, for instance, when she gets admitted to the hospital because she has, which is common for patients like diabetes across the country, a hypoglycemic event, low blood sugar. More often than not, we're just beginning to understand in healthcare that the root cause of stories like Mrs. M, diabetics who are getting hospitalized, especially at the end of each month across the country at a much higher rate. They're being hospitalized because of food insecurity. In other words, she's at the end of the month before she got hospitalized, she was taking care of her mom, she fed her mom and fed her kids, she paid the rent, she paid for all the utilities, and then she skipped her own meal because there wasn't enough food left over after taking care of everybody else. And yet she still took her blood sugar lowering medications. right? She was adherent to her care plan that we had come up with together.
And so I listened to this story. I've listened to it quite a few times now, and I'm so struck by what my approach would be if a patient had hypoglycemia. You know, my area of interest is clinical reasoning and how doctors think. And so I've taught hypoglycemia many times. I've grappled with it myself. And I have a very, very clear sort of algorithm of whether it's insulin mediated or not, and tests that can be ordered, just like I'm sure you do too, to sort of differentiate among those possibilities. And I realized how heavily biomedical that is. But what I realized more and more when I started to be taught by people to listen for stories like that, and then try in my own baby steps to ask about factors that aren't in normal medical teaching, was how often I was missing the mark. You know, a patient like Mrs. M is saying, why are you here? Why are you talking to me about titrating my meds and asking me if I check my finger sticks and et cetera? Because I have much, much bigger picture problems in my life. You know, why are you giving me more and more asthma inhalers instead of asking me about the mold in my apartment? Why do you keep prescribing a very expensive migraine medication without asking me if I can afford that? You know, patients are frustrated. It is so obvious to someone who lives that experience, and it's baffling that a doctor doesn't ask about that. And what I've learned is that if I don't live in that world and I haven't had that shared experience with a patient, I'm the one who's impoverished in terms of knowing what to ask. Because for a long time, I've been exceptionally proud of my differential diagnosis of hypoglycemia and relish the fact that I can recite it and think about it and do the test for it. But I recognize now that if I don't put something like a social determinants of health on the differential diagnosis, I may either call something idiopathic or, more importantly, errantly ascribe it to one of these things. What I've learned now is that social determinants of health shouldn't just be an afterthought. It shouldn't be at the bottom of the differential diagnosis. It should be one of the first and earliest considerations that I have. And that is one of the take-homes about what a clinician can do, is that when we go through our diagnostic process, to consider how the social determinants of health, diet, and environment, and education, and climate, can actually be responsible for someone's illness, not just an epiphenomenon of it. The next time, instead of saying, well, you have hypoglycemia that's complicated, you need to go to an endocrinologist, I might take a little more time to get to know her socially and say, you know what, you have hypoglycemia, it's complicated. I need to get you to a nutritionist or a social worker, and that's the expert that you need. Unpacking a little more of this idea about the social determinants of health. This was one of the more instructive diagrams, so I want to share it with you. As I mentioned, we are in the business as doctors of optimizing health outcomes. That means how long someone lives and what that quality of life is, and that remains very, very important. But when we put it in perspective, we learn that what determines those outcomes, is a series of health factors. And some of them are the clinical care that we provide. That's what we're talking about here. Much of healthcare in the last 10 to 20 years has been trying to optimize access to care and quality of care that we give. There's those health-related behaviors: smoking, exercise, alcohol, sexual activity. Those are things that we can engage in motivational interviewing to try to help people bring out the change for themselves, not because I sold them on it, but because they sold themselves on it. But then there's those other things that are at the bottom of the list, but they're actually at the base of the pyramid, about education and employment and income. And if there's any, if we need any stark examples of how important these are, you can just think about the examples about air and water quality, like Flint, Michigan water, or community safety. When we tell someone to go take a walk and they say, doc, it's not safe to walk after hours. Or we say, why don't you go get some fresh groceries? And they say, I have to take 2 buses to get to a grocery store that sells fresh food and not pre-processed snacks. Unless you ask about that and even envision that society can exist that way, it's very hard. And of course, we all know it when we hear it, it's just not front of mind. And the other point I want to make is that where do these health factors come from? How does the world even get structured like this? And this comes from really the policies and programs that oftentimes account for the world we live in. These are a lot of the isms that we don't like to talk about: racism, sexism, discrimination, imbalances of power, poverty. All of these things are baked into our system. Many of us don't like to believe it, and we certainly don't like to hear it, but some of them go back decades, and in some cases even centuries. And so when we're trying to fix it, you might say, well, listen, as a doctor, there's no way that I, in my own office, can fix all those things. And that's exactly right. No one is asking that you change the world. But I am asking, because I'm asking of myself, that in some small ways I can change my behavior. And so I've started to take a catalog of things that I can do in the clinic, and I've started to learn. And I have to say, Oftentimes the learning comes not from the doctors who are older than me. I've been in practice for 20 years. It's been in the doctors who are younger than me, sometimes only in practice in 2 years or even 2 months, because they're learning this, they're living it, and they are really thinking with new eyes about this. For instance, I've learned, as the example I gave, that maybe I should be giving a prescription not for a change in diabetes meds, but for a prescription to go to a food pantry. Or maybe I need to not send you to a medical subspecialist, but you need to see someone else on the interprofessional health team. And I write that as your prescription. Like the prescription is to see the social worker who can take care of your housing. Because I know once your housing is stable, then we can worry about getting you in for these PFTs, but not before then. I also learned that there are things that are baked into the law that I never knew about that help combat those social determinants of health. So if you remember my patient earlier on who had his heating in peril because he couldn't afford his electrical bill, I learned that in over 45 states, there are laws on the books where if the patient is low income and the physician writes a note saying that the utilities are essential for their patient's healthcare, the utilities can't shut off that service. And you can imagine that when I'm trying to talk to someone about coming in for a screening colonoscopy or getting a follow-up CT for a lung nodule, and they're worried about, will the lights stay on or will my kids have heat? There's no competition between those two. But sometimes I can help them with the thing that matters and will make their life stable and then allow them to attend to some of these health matters, which otherwise could easily go neglected. And although I'm not asking all the clinicians in this world to change the world, there should be no mistake that there are doctors out there who are trying to change the world. And I don't claim to be in this, so I want to be an honest, I'm trying to work honest broker here, but I'm in deep admiration of the people who are advocating online, on City Hall, in Congress, saying, listen, those policies and programs at the bottom of the list, they're responsible for this. And I feel an obligation for no self-interest of my own, but for the patients who I take care of, that we need to change it. And there's a small and growing vocal minority of doctors who are doing that. And I think there's sometimes no better spokesman than that. But I don't want to lay this just on clinicians. The title of this talk is What Clinicians Can Do. And I gave some examples here, but we also work in systems. And I think to really motivate, whether there's people who are leaders on this call who have the chance to pull some strings, or whether there's those of us who are in systems, it is really inspirational when we also see that it's not just me trying to do it, but it's the team that I'm around or the institution I'm in that also cares about it. And so to give you some insight into that, I'm going to share a video that's at San Francisco General Hospital, which is the safety net hospital in San Francisco, how they have tried to address this for the patients who come in their emergency room. I'll let you read this, it'll get louder in a second.
The emergency department, it works 24 hours a day, 365 days a year. It never takes a moment off, and neither do the patients.
We noticed that many of our patients have complex medical and social issues.
People come here to be cared for. They get a door that closes. They get things that you don't get outside.
A lot of people show up to the emergency room as their first point of contact for care for those things. Their medical needs were being met, they were being stabilized, but they really weren't moving forward. And so we set out to try to create a team in the emergency room to do all that. And so that's the context in which our program started.
Social medicine in general started out as an idea of how can we address folks' social needs in a setting where people are handling acute crisis.
What we're doing, it's recognizing that the most important thing that we do today may actually not be the medical problem. What we do when we're on rounds is ask people, what can we help you with today?
We benefit from the multidisciplinary nature and the skill set across our team.
We each have different levels of expertise, like pharmacists and social workers and nurses and physicians. And we apply those levels of expertise as a team for that person in service to them.
The social medicine program should be reproduced and will make a bigger impact as a result across and beyond San Francisco.
This team is incredible. They are smart, they are creative, they are dedicated, and they have big hearts.
And so I share that as a part of sort of admiration of my colleagues that do that, and admitting that there's nothing that I have at my hospital that replicates that, but knowing that that's being done sort of gives me some inspiration to try to recreate that for patients when I see them in the emergency room or when I'm taking care of them in clinic. And if for those who are in leadership positions, the motivation, sometimes you can make a financial case, but sometimes you make the ethical case or the mission case that that's the right thing to do. Sorry, let me move this over here. But one thing that I want to emphasize, and is my last point in putting together a portfolio of what we can do to help address the social determinants of health at the bedside, is recognizing one of the things that they emphasize, which is that was a team effort. It was a tremendous team effort, and you saw that there was a diversity in every which way, whether it was gender or race or skill set or department that the person came from. It takes a team, and I've always been fond of this sort of tagline that teamwork makes the dream work. And I've loved that as well. But that is true, and it's used oftentimes in slogans for teams and other places. But I've always loved Dwight Schrute's version of things, which is that teamwork makes for dream work. And by that it means like when you're really working in a high functioning team, your work starts to become awesome. It becomes very meaningful. And some authors like Patrick Lencioni have written about this extensively, how great teamwork is sort of like the strategic advantage of the 21st century. Just so few people can tap into it. But we really honor, if we have diverse patients that we're taking care of who come from all sorts of social circumstances, you have to create a diverse team to take care of them. There's no way that a doctor like me or anyone in the audience has all the skills or life experiences or perspectives to help that person. And to understand the importance of teamwork, whether we're part of one or we're assembling one, I just want to give you one more quiz and ask you first to say, do you recognize who these people are? And if you don't recognize them, I've shown you their mode of transport. If you don't recognize them, then I've explained what they are. This was the 1980s TV show called The A-Team. You may recognize it or be familiar with it for those who are around, but there was a short-lived but hit TV show where a group of vigilantes from the Los Angeles Underground, they're ex-veterans, really went on and did sort of vigilante justice, serving people because when the system itself failed them. And so they themselves were sort of crusaders for social determinants of justice instead of health. But one of the things about this is if you look at it, it has all the elements of the team. In fact, they love it when a plan comes together was a tagline of their boss. And they had diversity in a lot of ways. But I want you to think about this team and try to take that image if you remember them in mind. And if we can launch this poll, say, what dimension of diversity was missing from that team? Was it the health status of their members? Was it their racial or ethnic diversity? Was it the genders that they brought together? Was it the skill set? What was it that they were missing in that team? We'll give the audience some time to. All right, I think we can close out. We have about 56% of the votes in. And I think this sort of, Stan, if we can show the poll, I think we'll be able to convey the results here, which is, this is exactly right. All of them are worth noting. You'd have to really know the show to really know the answer of it if you didn't gather it from the picture. But health status there is some diversity in health status. For people who are fans of the show, you may know they had some health anomalies. Like B.A. Baracus had a fear of flying, which is a medical term. Murdoch was someone who had mental health disorder that they had to break out of the VA hospital, the place I do work at, every time they had a mission to go on. They had a wide diversity of skills. The skills between them were amazing, between mechanics and pilots and strategists. And the ethnic diversity, while not perfect, did roughly mirror sort of 3 white men and 1 black man. But what they didn't have was gender diversity, and that it was lacking until they brought on 1 other member, which her name was Amy. I'm sorry. And although it was a short-lived part of the show, it was a nod to the fact that you really, to make your best team, Amy was a journalist who did one thing that none of them could do, was actually get the word out and tell people what great jobs they were doing. And this underscores that that anytime we add a dimension of diversity, we do better. This graph is sort of an amalgamation of research in many, many areas, but it underscores a point I just want to mention, which is when we're trying to bring teams to serve diverse patients with all sorts of social experiences and life experiences, the more diverse we can bring them, the better, because we just think better that way. And we don't have time to review the literature, but it is in abundance that if we diversify in every dimension, the services we provide and the decisions we make improve. Here you can see as you go from gender and age and geography, and in healthcare, what I think is particularly important is health profession roles, nurses and pharmacists and social workers and therapists, goes on and on. And the key point that's here is that it takes effort to build a diverse team, and it takes even more effort to build an equitable team. There's a great article from Harvard Business Review that I read. It was by Joan Williams, who's I believe she's an organizational psychologist, but she says, you can't quite interrupt our biases, or sorry, you cannot undo our biases that trend us towards not building diverse teams, but you can interrupt them by structures. And so when we come to hiring these teams that take care of patients, we can do a couple things that I'll just touch on. One is we can insist on a diverse applicant pool. If I'm trying to hire nurses or fellow physicians or pharmacists, I can make an insistence that people are diverse by some dimension. We know that when the person who's hiring insists on having people who are underrepresented in healthcare, who are a certain gender, often women who are underrepresented, or a certain educational background, if they're insistent on being in the pool of applicants, then we have a higher probability of them being hired. And this has been shown again and again. We also have to recognize that if we're trying to diversify our teams, we have to go outside our usual networks. So most of us go into our social networks to try to find people to hire or place ads in places that are familiar to us. But what we wind up getting is people who look like us. And we often fall in the trap of saying, well, I need a cultural fit with my team. But you don't need a cultural fit. What we really need is a values fit. Like if they value kindness or compassion or knowing the whole person, that's what you need. You know, when we hire, I'm not trying to hire a guy to go out for a beer with. I mean, if that's the job, yeah, I need that. But otherwise, I don't want to say I'm looking for someone who I'd like to have a beer with. I'd like to have someone on my team who cares about patients in the same way I do and respects their entire life experience and world experience that they have, and maybe can triangulate on a way that I can. And the last part of the puzzle is that when we build a multifaceted team, it's not enough just to pat ourselves on the back and say we've hired for diversity, whether it's ethnicity or gender or profession or skill set. You still have the problem of the in-group and the out-group, which is to say when someone who's an out member of the group joins a team, they still are generally given less leeway, given less support for their ideas, and oftentimes made to follow the rules in the way the in-group doesn't have to. And it's never written that way, but that's the nature of how we run groups. So really great interprofessional teams that we try to bring together to give patients great service that takes care of not only their biomedical needs, but also their psychosocial needs and their social world they live in, inevitably have to flatten the hierarchy. And we have an interdisciplinary team here at our San Francisco VA. This is shown here. And one of the things I've learned from reading about this is how you run a great team. So the typical format will be that a doctor will start the meeting and run the meeting. And when that happens, sure enough, like people sort of talk and say their thing, but often it's people who are least empowered in the group, like perhaps the medical assistant or the social worker who's brand new to the team doesn't speak up, even though they always have something good to say and they know something that runs the clinic late, and we never catch on, the doctor does ourselves. And people who understand this flatten the hierarchy by doing things like having the doctor speak last, so everyone can have their voice heard first. Or even better, they say, you know what, I'm gonna have the MA run the meeting, and he or she is in charge of this meeting, and they get to determine who gets to speak. It's a very small gesture, but it's a highly effective one that says, I value the team so much that I want this team to be equitable in every way, because when we do that, we serve our patients and the world they come from best. And as my summary slide, I want to say that addressing the social determinants of health is challenging, but it is possible. The thing that I've come to learn to think of when I first heard about it was like, oh, am I supposed to fix the world because all these social problems cause health problems? And the answer is no. But we have to understand the different spheres, like what I can control of myself. And I hope you got the message that we can control some of our own blind spots. We can lead with compassion that allows people to understand we respect them as human beings, that we get a real social history and be social and react with people. And then when it comes to the diagnostic and therapeutic thinking, that these social determinants of health are on the DDX and the social determinants of health are on my RX menu as well. Clinicians also do have a sphere of influence, and if some of us have the chance to do this, whether it's affecting systems or policies, or as the example I gave, building teams in our clinic or our ward that might take care of patients, to think about being deliberate, to build a team that really helps people combat the social determinants of health, to complement the biomedicine that the doctor often brings. And then finally, there is still that dimension of advocacy, and that is really important. And while only a small subset of doctors do it, I don't want to undermine its importance. It's probably the only way we'll make substantial change. And so my final video is just a summary of all these spots to sort of give us some final tips and emphasize this, that really, we started this saying, well, what is it that determines someone's health? What's personal medicine? It's not really, we think it's their genetic code, but increasingly, it's their zip code. And so this video finishes us up on the story of that I character and tells us some of the final steps that we can take. I'll bring that up here.
But as health clinicians, there are things that we can do to make a difference. Look beyond the illness to see the whole person and try to understand the reality of their daily situation. Ask them what they think would make a difference to their lives and really listen. It may be that taking care of their health in the way you suggest won't be easy. It may make things more stressful for them. So try and see what other support you can offer. Advocate with them and give them knowledge on where to turn for help. Offer transport options for people to come to your service. Consider food vouchers to families who are struggling, or talking to nutritionists who can work with people to cook a healthy meal on limited income. Offer medications for longer periods of time for people who can't get to a pharmacy easily, and refer people to other services like counselling or housing assistance. Help improve their health literacy by encouraging and working with them to better understand their illness and be more active in their own health care. Even one small action, like really listening and being compassionate, can go a long way to improving their health. Changing your practice, even ever so slightly, might mean the world of difference to someone.
And I love that notion. Just changing our practice ever so slightly could mean the world of difference to someone else. So I know the hour is late. I thank everyone for your time. I wish all of us Godspeed in our effort to our proven practice in this way and in every way. Thank you so much for your attention.
Dr. Dhaliwal, I'm so sorry we're out of time. Somehow you turn every sentence, I think, in every story into a pearl. So
thank you.
Thank you for bringing this incredibly important topic down to the bedside, so to speak. Thank you to everyone in attendance, and our deep gratitude to you. Thank you so much.
Thank you so much. Thank you to everyone who came together tonight. I wish you all Godspeed. Thank you. Good night.
Good night, everyone.
Good night, Stanley, Jerry.
Good night, Dr. Dhaliwal.